Today, we are going to be discussing dissociative disorders and somatic disorders. Again, these may not be very commonly seen in your practice, and these disorders may be very rarely something that you encounter, but we're still going to explore them and get a very good understanding of both of these types of disorders. So, let's begin our exploration of dissociation, which includes depersonalization, derealization disorder, dissociative amnesia, fugue states, and dissociative identity disorder. While many people are familiar with these disorders through movies and television shows and various different types of media, it's important to note that these portrayals are not entirely accurate. What are dissociative disorders and what is dissociation? Let's begin by defining dissociation, which occurs when part of cognition or experience becomes inaccessible to the conscious awareness or is repressed into unconsciousness. Typically, dissociation involves avoidance response and some form of harmless and common, while others can lead to safety concerns or can cause harm. For example, a mild form of dissociation may occur when someone loses track of time or drive somewhere without remembering the journey. Now, this can be kind of thinking of someone like being on autopilot, where you go maybe from work to home, a drive that you do all the time without conscious awareness. That's going to be very normal. For the most part, it's going to be relatively harmless. Your brain is just somewhere else. Now, conversely, with these types of disorders, that's not necessarily the case. The key question is whether the dissociation is going to cause significant distress or impair functioning. More severe forms of dissociation can include losing track of time, getting into accidents while driving. Periods of dissociation may last for hours or even days. So you can see that this is a much more extreme form of what a typical person may experience on their 20-minute commute. In dissociation, there's a sudden disruption of the continuity of consciousness, emotions, motivation, memories, and identity. This disruption is central to understanding dissociative disorders, which we're going to continue to explore. One of my favorite media portrayals of dissociative disorders is called The United States of Terra. I really enjoy that show. I think that out of the many, many different media portrayals out there, it is one of the more accurate ones. So if you want to, it's still a fictional scripted show, but nonetheless, I think that they've done a nice job with it. So if you want to explore more, that is a potential option for you. It's called The United States of Tara, T-A-R-A. Tara is the name of the main character. Okay. How does memory work under stress? Well, the trauma module that we discussed, how the brain processes and stores information, so we're going to kind of pull off of that. There are various perspectives on how this actually occurs, but from a psychodynamic standpoint, traumatic events are often repressed, and certain treatments aim to reintegrate those fragmented memories. So we can think about the model in which it is believed that during a traumatic event, individuals may quote unquote check out in order to survive, retreating to the back of the brain where the fight, flight, or freeze response remains dominant. And in this state, the brain records information very differently. So, from a cognitive perspective, extreme stress typically enhances memory rather than impairs it. For example, during a car accident, the heightened stress causes everything to feel as if it's happening in slow motion because the brain is hypervigilant and processing every detail. However, certain memories may become inaccessible later on, as the brain may block out some details. That's why, in cases of extreme trauma, people may have gaps in their memories. Now, let's discuss memory deficits in dissociation. Memory deficits are typically observed in explicit memory, but not implicit memory. So, what's the difference? Well, explicit memory refers to the conscious recall of experiences such as remembering, say, for example, your senior prom, your mom's birthday. In implicit memory, on the other hand, that involves tasks that are performed automatically, like playing tennis, riding a bike, writing a check, driving a car, skills that have become second nature through repetition. So, when we talk about dissociation, the deficit usually affects the explicit memory. So, this means that while some individuals may still be able to perform automatic tasks like cooking, something that they're very used to cooking, or tying their shoes, they may struggle to remember the entire day or specific events. When distinguishing dissociation from other causes of memory loss, we must consider several key factors. For example, as we learned earlier in the semester, dementia can lead to memory loss, but it's unrelated to dissociative processes. We also need to rule out other possible causes such as memory loss from a TBI, traumatic brain injury, or memory impairments due to substance use where the individual experiences blackouts. These conditions must be considered when diagnosing dissociative disorders. There are assessment tools to help clinicians with this. One of them is the Dissociative Experiences Scale, and this scale is commonly used to assess the frequency and severity of dissociative experiences in individuals. Now let's discuss the primary disorders involved in dissociative symptoms, starting with depersonalization derealization disorder. In this disorder, individuals' perception of themselves is altered, often triggered by stress or a traumatic event. However, the memory is not affected. There is no psychosis present. The disorder is commonly comorbid with anxiety and typically first occurs during adolescence, though it can become chronic. It's important to note that symptoms cannot be explained by substance use, another dissociative disorder, another psychological condition, or a medical issue. In depersonalization derealization, the way that the person perceives themselves and their personality is significantly altered. So, what are the criteria for this particular disorder? Well, as we can see here on this slide, it is typically a sensory experience. Individuals may feel that their limbs are deformed or enlarged, or that their voice may sound distant or altered as though it's coming from far away. Feelings of detachment or disconnection from oneself can also occur, where a person feels as though they're being observed, they're observing themselves from an outside perspective, or maybe they're floating above their own body. These are signs of depersonalization or derealization, where the individual feels separated from themselves. Derealization can feel like the world around them has become unreal or dreamlike. Objects may appear strange, flat, two-dimensional, and they may have difficulty experiencing emotions such as feeling numb or robotic, or feel like they're operating kind of like mechanically. Symptoms tend to persist or return over time. Reality testing remains intact, meaning that while the individual may feel detached or unreal, they still know the date and the time and they are grounded in reality. They are not living in a hallucination or experiencing delusions, and these symptoms cannot be better explained by substances or other dissociative disorders. For example, alcohol and drugs may induce similar feelings of detachment or distortions, but in this particular disorder, the alterations are in self-perception and reality is persistent, but the individual remains aware of the real world around them. So while you may not encounter dissociative amnesia very frequently at all, it's important to be aware of these symptoms. If you do come across them, you may be more likely to come across this in a hospital setting. But if you do come across it nonetheless in whatever setting that you're in, you can refer for appropriate treatment. Dissociative amnesia is often depicted in movies where someone suffers from memory loss and then kind of just begins a new life, only to be reminded of their past life when they encounter someone familiar. This is not always the case. Again, don't believe everything that you see with regard to mental health in the media. In dissociative amnesia, individuals experience an inability to recall important personal information, typically related to a traumatic or stressful event. This amnesia cannot be explained by substances. It's important to rule out other potential causes like a traumatic brain injury or dementia, like we've discussed. There are different subtypes to specify which of these when amnesia is accompanied by confusion or purposeful wandering, where the individual may appear disoriented, moving from place to place, kind of like they're in a fog, or trying to piece together their thoughts. Dissociative amnesia often occurs after very extremely stressful events like a sexual assault, an accident, ongoing abuse, or combat. In these cases, individuals may forget entire sections of their life as a way to cope with that trauma. Dissociative fugue subtype refers to a person who experiences a sudden, unexpected journey, often wandering in a disoriented state. And this is something that whenever we think about the word fugue, fugue comes from the Latin word to flee. And in this case, individuals may travel without remembering their past or the reasons for their action. They may leave their life behind and moving in a purposeful direction, but without a clear understanding of why. And these episodes may be very short duration. At some point, the individual may suddenly become aware that they have wandered and wonder how they get there, realizing that they need to get home. And this may be particularly frightening for both the individual who's in the fugue state as well as the family members who are left concerned and confused about how that individual ended up in an unfamiliar location. The criteria for dissociative amnesia also involves the inability to recall important personal information, typically related to traumatic or stressful events. The memory loss cannot be explained by other causes, such as, again, substance use or medical conditions. The fugue subtype is diagnosed in addition when there is amnesia, if there's confusion about one's identity or an assumption of a new identity, often accompanied by a sudden, unexpected travel away from home. And in these cases, the individual may adopt an entirely new identity because they are unable to recall their past. Again, while this is rare, it does occasionally happen. Okay, the moment you've been waiting for, DID, Dissociative Identity Disorder, formerly known as Multiple Personality Disorder. We no longer call it that. It is now Dissociative Identity Disorder. I'm going to call it DID. You'll see this portrayed in the media very often, and it's very much misunderstood. While the disorder is sometimes sensationalized, it's important to recognize its clinical characteristics. DID is characterized by the presence of two or more distinct and fully developed personalities, which they're very unique in their own way of thinking and feeling and behaving. So those are called alters, and then the primary identity is called the host, and the primary identity or the host may be unaware of the existence of the other alters, which means that the individual may not recognize these shifts in their identities, though others around them may notice these changes. DID typically has an onset in childhood, but may not be diagnosed until adulthood. It is more common in women than men. It is very frequently associated or co-occurs with PTSD, major depression, and personality disorders and somatic symptom disorders. It's essential to note that DID is distinct and different from schizophrenia. DID may include a disruption of identity, characterized by, again, like we discussed, two or more distinct personalities. Individuals with DID experience recurrent gaps in memory, especially when transitioning between the alters. These symptoms are not part of a culturally or religiously accepted practice. Additionally, symptoms may not be attributed to drugs or a medical condition, or an imaginary playmate that a child may have. In young children, the creation of imaginary worlds or play is typically part of their neurological, emotional, and social development and does not necessarily indicate DID. Instead, that is something that we would absolutely expect to see in a child. The symptoms of DID may be very complex and varied. In this diagram, we'll see that individuals may experience passive influence, such as feeling as though their alter is exerting control over them, or hearing internal voices that lead to intrusive thoughts, feelings, or urges. There can be changes in memory skills or preferences, especially when the person identifies with one alter that is completely distinct from the others. For example, one alter may have different tastes or even feel like a different person entirely. In the show that I referenced earlier, The United States of Terra, the individual character, or I should say the host, the primary identity, is a middle-aged female, but one of her alters is a male who likes to ride motorcycles. Another one is a teenage girl. So these alters may be very, very different. Some alters may they may be even like as young as a child, and that's the same thing you'll come to find in the United States of Terra as well. Common symptoms include identity confusion, amnesia, flashbacks, and disassociation, leading individuals to feel as though they are different people at different times. In a study on dissociation, conducted alongside with a patient identified as part of a research study, physiological changes were observed in the brain. Specifically, alterations were noted in both the left and the right hemispheres. You'll see that with the arrow indicating there. as well as in the back region of the brain. Now, these changes indicate that the disassociation is not a voluntary act or simply quote unquote checking out. Instead, it is a genuine physiological response with these changes occurring in the brain when the disassociation takes place. There are some important considerations regarding the development of dissociative identity disorder. Before the 1880s, there were no documented cases of DID or dissociative amnesia. However, it's important to note that during this time period, people lived in very different conditions, and various factors may have influenced the absence of reported cases. There was a significant increase in the rates of diagnosing DID in the 1970s, raising the question as to whether DID always existed or if it was simply underdiagnosed, or if environmental factors are contributing to the rise of the diagnosis. In the DSM-3, published in the 1980s, specific criteria for diagnosing DID were introduced. However, these specific criteria have since become more implicit and somewhat vague, and we've gained a better understanding of how to recognize the early signs of this disorder. Stigma continues to play a very significant role in public perception of DID. Again, I think that this is even noted in, it used to be called multiple personality disorder, and we no longer call it that. So I think that there's even stigma around that old name that we used to use. Again, there's going to be lots of appearances of DID in pop culture, like Sybil, The Three Faces of Eve, Split, things like Criminal Minds. There's lots and lots of attention and kind of fascination around DID, especially portraying the individual as someone who's dangerous or uncontrollable, which further just creates more stigma and misconception around this disorder. There are two primary theories regarding the etiology of DID. First is the post-traumatic model, which suggests that DID results from severe neglect or abuse, particularly in early adulthood. As discussed in previous modules, the brains of children who experience significant neglect are often smaller and less developed than those who do not. However, due to the rarity of DID in the general population, there's no prospective studies that have tracked individuals over time. Some studies are currently underway, but we're not likely to see anything of those in quite a while. The second theory is the social cognitive model, which boasts that the DID may be a form of role playing in highly suggestible individuals. This theory suggests that DID could be iatrogenic, meaning that it arises as a result of prompting by the therapist or media exposure. In this case, the individual is not intentionally deceiving anyone, but may switch identities in response to external cues or to fit a certain narrative suggested by others. This model is less widely accepted compared to the post-traumatic model, which remains the more prevalent and supported explanation for the development of DID. The theory debate surrounding DID includes evidence suggesting that it may sometimes be role-played. A study conducted in 1985, particularly following the release of the book Sybil, which was very popular at the time and still is, involves hypnotizing students and prompting them to reveal alternative identities, which they did. This raised concerns about the possibility of role-playing the DID diagnosis. Further studies have shown that DID patients often exhibit only partial implicit memory difficulties, and in some alters, they are able to share memories. Research conducted in 2003 found that despite alters not being aware of each other, they can still experience shared memories or perceptions since they are inhabiting the same body. Additionally, DID diagnoses may vary significantly by clinician, with only a few clinicians diagnosing the majority of cases across the country. Many patients report more symptoms emerging after therapy begins as they become more aware of the condition. Given the findings in the studies spanning from 1985 to 2003, as well as more research in the last several years, it is clear that DID is a valid diagnosis. However, it's important to consider all the factors that may impact its development. Environmental influences, trauma, and the role of therapy all contribute to how the disorder emerges and how it's understood. Treating DID requires an empathetic and supportive therapeutic approach. The therapist and counselor can play a crucial role in the effective treatment for a DID, particularly when working alongside a psychologist, psychiatrist, or just an entire treatment team. The goal of treatment is to integrate the different alters into a single fully functioning host or person. One treatment modality often used in trauma therapy is called parts therapy, which focuses on helping individuals understand and integrate their various different parts. Improving coping skills and enhancing the individual's ability to handle daily stressors and triggers is often a crucial component of treatment. In some cases, psychodynamic approach may be employed with the goal of overcoming repression and facilitating the integration of the alters. Some providers may incorporate hypnosis, although it's not commonly used in therapy and counselors are generally not trained in this method. It's important to note that hypnosis, while sometimes depicted in the media, is distinct from EMDR, eye movement desensitization and reprocessing. And in fact, hypnosis can actually worsen symptoms, particularly in cases of severe trauma and disassociation. Given the complexity in treating DID, it is essential that clinicians are properly trained before attempting to treat these disorders. In many cases, knowing when to refer a patient to a more specialized provider will be critical to really make sure that we're getting the patient the best possible care that they can have and avoiding making the situation worse. All right, let's move on to somatic symptom disorders. Okay, so here we're going to talk about the various different theories of etiology, and we're still evolving and continuously evaluating these types of uh, disorders. But we're going to work through the theories to help inform our understanding and guide how we approach working with clients. Okay, here we are going to be looking at the various different disorders, which include somatic symptom disorder, illness anxiety disorder, conversion disorder, malingering, and factitious disorder. Again, these are still less common, but we're briefly going to at least go over them. And here, malingering, when we talk about this involves intentionally faking psychological or physical symptoms to achieve some type of gain, such as avoiding responsibility or gaining sympathy. So this may be malingering, may be something that we're going to see more so in, say, for example, a forensic setting where someone is malingering something in order to maybe get a less severe treatment. Whereas factitious disorder, on the other hand, involves falsification of symptoms without any clear gain. More so, whenever it comes to malingering, there is a benefit, there's some type of secondary gain, whereas with factitious disorder, the person isn't necessarily seeking a external reward, but maybe they are getting sympathy or more attention than normal, perhaps. So what are the DSM-5 criteria for somatic symptom disorder? This disorder is characterized by at least one distressing somatic symptom, accompanied by excessive thoughts, feelings, or behaviors related to that symptom or health concerns. This may include health-related anxiety, disproportionate worries about the severity of the symptom, and an excessive amount of time and energy spent on health concerns. These symptoms must persist for at least 6 months, and as always, we must consider the time frame. We must specify whether the symptoms are, which ones are predominant, meaning that they are significantly impacting the individual's life. The criteria for illness anxiety disorder is going to involve a preoccupation or high levels of anxiety about having or acquiring a serious illness or disease. This excessive anxiety leads to behaviors such as repeated checking for symptoms or frequently seeking medical reassurance. Unlike somatic symptom disorder, which the person does have somatic symptoms, or at least one, with illness anxiety disorder, there's really no symptoms, or if there are, they're extremely mild, if any. The focus for illness anxiety disorder is primarily on anxiety related to the health of oneself, and the concerns are not better explained by other psychological disorders. In somatic symptom disorder, the symptoms must persist for at least 6 months. The key distinction here is that with illness anxiety disorder, it is much more anxiety driven. It's in the name, with fewer somatic symptoms. And while the somatic symptom disorder involves a more pronounced physical symptoms and preoccupation with those physical symptoms. Next is conversion disorder, and on this continuum, we continue to move. We encounter cases where sensory or motor function is impaired without, important here, without any neurological cause. For example, Individuals with conversion disorder may experience symptoms like being blind or tunnel vision, paralysis, seizures, whispered speech, or loss of smell. There's no physical or medical explanation for these symptoms. This type of disorder was explored in some of our previous readings. So this is going to be something that is unique to conversion disorder. Again, there is no known neurological cause. Now, historically, conversion disorder has been believed to only affect women, much like hysteria. This view dates back to ancient Greece, and it was thought to be caused by a quote unquote wandering uterus, where that's where the term hysteria originates from, being the Greek word for uterus. However, now this view is considered invalid and highly outdated. But history of this belief reflects the stigma and the misconceptions that have influenced the understanding of this disorder. Moving on to our favorite man in psychology, Freud. He used the term conversion to describe how anxiety and internal conflict could be converted into physical symptoms. A notable example of his is a famous case of Anna O, whom Freud treated for conversion disorder. So if you're interested, you're welcome to explore that more. The criteria for conversion disorder includes one or more symptoms affecting voluntary motor or sensory function. These symptoms are inconsistent with any recognized medical condition and must cause significant distress or impairment in functioning or require a medical evaluation. Typically, conversion disorder has an onset in early adolescence or early adulthood, often following, this is important, a significant life stressor. This stress commonly arises from a major life transition, perhaps leaving home for the first time, or a disorder has a prevalence of less than 1% in the general population. It is more common in women than men, contrary to beliefs that we just talked about on the last slide. It is not exclusive to women. Conversion disorder is often comorbid with other conditions, such as somatic symptom disorder, major depression, substance use, and the like. Okay, this chart illustrates how conversion reaction can develop. It begins with the accumulation of life stressors or abuse, with the triggering event shown in yellow. The perpetuating factors represented in white there often are seen in individuals with poor emotion regulation, impairments in emotional processing, and this can affect sensory motor system. There are often a minimization of psychological factors, and many individuals with conversion disorder exhibit a lack of internal locus of control, meaning that they struggle with self-regulation and self-control. Instead, they tend to rely on others, indicating an external locus of control. Okay, some factors or some red flags may include family and societal or sociocultural influences and cognitive impairments, as well as genetic and neurochemical and hormonal changes in the brain. Family and sociocultural factors are especially significant. If one family member experiences conversion disorder, it increases the likelihood that others will develop it as well. Additionally, this disorder is often comorbid with psychiatric conditions such as major depression, trauma, and substance use. These risk factors perpetuate and may help along other specific triggers that can contribute to the development of conversion reaction, leading to symptoms such as loss of sight, loss of smell, or even paralysis. When treating disorders like conversion disorder and somatic symptom disorder, it's essential to help individuals develop self-awareness and emotion regulation. CBT is commonly used, often incorporating coping strategies. Strengthening positive social supports and relationships is also a key part of treatment. By improving a person's ability to manage emotions and anxiety and somatic symptoms, or in the case of conversion disorder, physical symptoms like paralysis can often diminish. Let's discuss factitious disorder. As the name suggests, it involves fabricating or falsifying symptoms without any external rewards. The deception behavior occurs in the absence of other psychological disorders, and it is imposed on the individual who presents themselves as ill, impaired, or injured. In some cases, this disorder is inflicted on another person. You may have heard about this before. It's called Munchausen's by proxy, where a caregiver intentionally causes illness or harm to someone to gain psychological benefits. Although there is no clear external reward necessarily, it is the psychological benefits or the attention or the sympathy that the person is really interested in. While factitious disorder is rare and often not often diagnosed, it's important to understand, especially because it sometimes involves a caregiver causing harm to a dependent. So, unlike malingering, there is an identifiable external gain that does exist. Factitious disorder involves the deceptive behavior without an obvious reward. It's important to explore case studies as well as real world examples to really have a good understanding. Regarding the etiology of these disorders, there is limited evidence of supporting the genetic influence. However, sociocultural factors play a significant role as families experiencing similar stressors may exhibit patterns of these disorders. Twin studies show no significant differences in concordance rates between monozygotic twins. Individuals with somatic or conversion disorders may also have brain changes, specifically the anterior insula and the anterior cingulate are often hyperactive, which suggests that somatic symptoms are strongly influenced by emotions and stress. When emotion regulation is poor, the limbic system is in a heightened state of alert, and these disorders are more likely to occur. The etiology of these disorders also involves two key cognitive factors: attention to bodily sensations and attributions we make about those sensations. This includes an automatic focus on physical health cues, an overreaction or negative interpretation of bodily experiences. The two main consequences of this pattern are the sick role, which restricts healthy lifestyle alternatives and help seeking behaviors, which are reinforced by receiving attention or sympathy from caregivers or medical professionals. As individuals receive more attention for their symptoms, this reinforcement can make behaviors more ingrained, particularly in the case of somatic symptoms. The mechanisms involved behind these disorders involve a cycle of medical symptoms. It begins with emotional arousal and psychiatric disorders, which then lead to a heightened attention to bodily symptoms. This attention triggers health anxiety, which in turn fuels health seeking behavior, avoidance, and disability. Social responses such as attention and care from others can further reinforce this cycle, and it becomes a self perpetuating cycle in which symptoms are noticed, help is sought, and positive responses are received, leading to continued help seeking behaviors. One of the key goals of therapy is to break this cycle by fostering self awareness and improving emotion regulation. The etiology of conversion disorder involves a phenomenon called a blind sight, where individuals are not consciously aware of their visual input, and there's a failure to explicitly recognize sensory information. This often stems from unconscious psychological factors such as underlying fear or trauma. As a result, individuals may genuinely believe that they are experiencing these symptoms, even though they're not fully aware of these psychological influences behind them. Despite the lack of evidence to the contrary, individuals with conversion disorder may genuinely believe their symptoms. When considering social and cultural factors, it's important to note that the incidence of conversion disorder has decreased since the latter half of the 19th century. Prior to that time, the disorder was more common, potentially due to societal repression of sexual attitudes and a low tolerance for anxiety related symptoms. Without accessible treatment options, these symptoms often manifested in ways that could not be fully expressed. Anxiety, for instance, is known to cause somatic symptoms like stomach issues, vomiting, increased heart rate, and sweating. If there's no outlet for emotional expression, these symptoms could escalate over time. Today, these symptoms are more prevalent in rural areas and among individuals of lower socioeconomic status, especially in non Western cultures where treatment may be less accessible. This underscores the complex role of stress, environment, and cultural factors in the development of conversion disorder. So, treatment for these various different types of disorders has been somewhat difficult to track due to their low prevalence and challenge in controlling and conducting studies. However, again, CBT pops up, is widely considered an effective treatment approach. CBT helps individuals identify and change emotions and that trigger symptoms and improve emotional regulation and reframe the distorted cognitions about their symptoms, allowing them to differentiate between reality and their perceptions. The goal is to replace the sick role where the individual develops healthier social interactions, helping individuals gain social reinforcement without relying on physical symptoms. In the cases like anxiety, learning to control internal anxiety can prevent somatic symptoms from manifesting. And then at the very bottom there, you've got antidepressants. SSRIs, such as Prozac or Lexapro, are often prescribed to manage anxiety and depression, increasingly even at low doses. And medications can help reduce somatic symptoms without necessarily addressing the underlying depressive symptoms. Medications such as tofranil, you see there, are also thought to be somewhat effective. And that concludes our review on dissociative and somatic symptom disorders. Thanks for your time and attention, and I'll see you in the next one.